So good afternoon, everyone. I'm Gráinne Healy, Chair of the Sláintecare Citizen and Staff Engagement Forum, and I'm really delighted to welcome you to today's webinar, the second Sláintecare Integration Fund webinar as part of our Learning Network event series. I want to thank those of you who sent in comments and suggestions after webinar 1. We hope that any technical problems you had with login have been sorted, and we really want to thank you for the lovely messages of support for the webinar series that many of you sent in. Listening to your feedback after webinar 1, we are taking questions during the broadcast, and we will be making the questions and answers available to you after the webinar. So if you're asking a question or making a comment, please do indicate who the question is for, and we will make sure to get the answers from our guests live during the webinar or from the team or the guests afterwards and post them up for you. So please use the chat box function, which is the feature in the top right-hand corner of your screen, to send in questions or comments. We are very happy to be delivering these webinars in conjunction with the HSE, the Health Service Executive, and also with the support of IFIC, the International Forum for Integrated Care. Sláintecare is, as you know, about providing the right care in the right place and at the right time. And we've lined up 4 webinars in which you'll hear how the projects funded by Sláintecare Integration Fund and some of the HSE funded work is showing us best practice for healthcare reform and how they have adapted and responded in particular during COVID-19. Today, though, our focus is on new ways of working to provide integrated care. We'll hear from health and care providers who have adapted their work over the recent COVID-19 pandemic period, all leading to improvements in health and social care outcomes. We'll also hear from senior health professionals to get an overview on their experiences of welcome new ways of working, fitting with the Sláintecare objectives. Today's projects show the linkages being made between GPs and hospitals and local community services. We have 7 social prescribing projects to present from right across Ireland, all working to link patients with activities in their local communities which have positive impacts on their health. We also hear about the creation of a virtual ward in Cork Kerry and a new social inclusion initiative developed during COVID-19, again in the Southwest. So new ways of working to provide integrated care are key to delivering Sláintecare. Most importantly, they're bringing huge benefits to patients, while many are also reducing the need for GP or hospital visits, while enhancing the mental and physical health and well-being of so many people. We'll be bringing you more new practices in the forthcoming webinars, and some of the suggestions you have made in your feedback will feature in those webinars. Our next one is on the 30th of July, and it will feature chronic disease management and some really interesting innovative developments there, where they're delivering right care in the right place at the right time, leading to better patient outcomes through enhanced flexible health and care systems. But first, this afternoon, we're going to hear from Dr. Colm Henry, Chief Clinical Officer with the HSE, and then we're going to hear from Chief Nursing Officer Rachel Kenna. I spoke to them earlier and they told me about new ways of working which they've seen, especially during COVID-19, and they tell us why they want to see these new ways of working continue as part of Sláintecare delivery.
So before we hear from our projects showing new ways of working towards integrated care, I'm really delighted to have been joined this afternoon by Dr. Colm Henry. And Dr. Colm Henry, as you know, is the Chief Clinical Officer at the HSE, and he's also a member of the Sláintecare Implementation Advisory Committee. Yeah, you're very welcome, Colm. Thank you very much for joining us. Colm, would you talk to us a little bit about, in the particularly in the context of COVID-19, some of the welcome change in practices that you've seen that you'd like to see continue?
Thank you, Grania, and thank you for having me on the webinar. I'm delighted to contribute to this discussion, not just as part of the Sláintecare group, but also in my role as Chief Clinical Officer of the HSE. So it has been an extraordinary and unprecedented time since our first case was identified in February 29th, but our planning went way before that, when we first became aware of the distant warnings of COVID-19 in the Far East and then nearer to home in north of Italy. And our whole preparation at the time was based on what we were seeing was happening in the north of Italy and in China, and in preparing at speed a healthcare system to adapt to something we felt would overwhelm our healthcare system and threaten great loss of life throughout the country. And I'm reminded of those important words of Mike Ryan, or the Irishman who's on the WHO, where he said there's an absolute prerogative to act, and that speed trumps perfection. So what made things different for us looking back was we had to act. We didn't have to seek permission. We had to ask forgiveness after. And that really, that principle underpinned more or less all of our actions in those first few months, where for the first time in my memory, in this role that I have now, or in any other role in the HTC, we were doing things, establishing things, setting things up without fear of them failing. The main fear we had is that we would have to, that any delay would hinder our ability to react and respond in time to the crisis.
So in terms of the new ways of working, maybe that had to be developed and were developed so speedily, do you want to pick out maybe one or two of the ones that you think were absolutely crucial and that you really welcome and you'd love to see them continue?
Well, the first phase, of course, was the focus for us was preparing our acute hospital system. But in doing so, we were establishing services out in the community at speed, going back to that directive again, that speed trumps perfection, including community assessment hubs for the assessment of people with suspect or confirmed COVID-19. But as we enter this next phase and look forward with some trepidation to the winter that's coming, where we won't just have COVID-19, but we'll have RSV and perhaps influenza as well, the establishment of community hubs where we can assess people with respiratory disease, undifferentiated respiratory disease, where we can complete a cycle of care within the community without necessarily depending on diagnostics from the acute hospital system, and where we can reduce footfall in hospitals and build resilience in the community. Those are the themes that we're now doing at speed. And it's notable that the Sláintecare program, as we know, was an ambitious program, but over a long time period. Well, COVID-19 has changed all of this. We're not looking at changing things over a 10-year period anymore. We're looking at doing it within the projected lifespan of COVID-19, whatever that may be. But it begins now for this winter, and it will certainly last at least 1 or 2 more winters.
Right. So a really ambitious piece of work then in a much shorter, more intense time frame. What do you think are the key enablers? You talk about reducing footfall, being able to do more community-based work to avoid admissions through emergency departments. What do you think are the key enablers to help that to happen in the time frame that you're now saying we need to do it?
Well, one of the there's so many good things happened in the face of something that was so bad and so evil as this virus has been. And one of the good things was the high level of collaboration between professional groups at a level I've never seen before, where grievances were set aside and interests were set aside, and people just wanted to be enabled to do the right thing. And if I could give you an example, the primary care community had infinite patience with us as the case definition changed so quickly, which led to huge demand on our testing regime, which started at a very small scale and then went up to 49 swabbing centres and almost 30 labs doing the testing. So working with the key, listening to general practitioners who've been really in constant communication with us throughout this crisis. They have had the same consistent demands for what they need. It's not just about avoiding footfall in hospitals, it's about making their job easier in the community. And that means bringing services out into the community, bringing diagnostics out into the community, not just in terms of the range of diagnostics, but the timeliness of diagnostics, bringing specialist opinion out. working up new ways of working, such as virtual clinics. We saw extraordinary figures during 1 month of, I think, April, totaling 80,000 virtual consultations in 1 month.
Wow.
Very low base. So these changes were brought upon us without the usual cycle that we have in the HSE of planning, of design, of trial, of piloting, of getting seed funding, all of which sometimes serves more to delay doing what's right rather than allow you to do what's right.
Very good. So if you were looking to the future then, are we talking about more planning, more collaboration, more resources to get it done in the time frame that you want it done in?
Well, the lessons for us were because we really had to work with people, and we were working in a very intense way with these different professional groups, and include unions in that, who again, I couldn't speak more highly of their role, and not just in advocating for their members, but also in bringing innovative suggestions as to how we deal with PPE and other challenges we had throughout the crisis. The best ideas came from the coalface, came from general practitioners who said, allow us to do this, and we will be able to complete cycles of care within the community. And hospitals, critical care, the same thing. It was about giving permission, not just giving permission, but listening and allowing people to take chances, to take risks. We said at the very beginning we wouldn't get everything right, but if we would be lucky if 70% of our decisions and the things we set up would be successful, and that's probably been about right. And some of the services we set up we didn't need, thankfully, because the surge didn't come at the level at which we feared at the beginning. But nevertheless, the extraordinary learning for us was what happens, the kind of magic that happens when there's that synergy of interests and collaboration and a feeling of everybody wanting to do the right thing. Is amazing things can happen in a short time frame.
Very good. So we need more of that. Dr. Henry, thank you so much for joining us this afternoon. I really appreciate your time. Keep up the good work. Thanks a lot. Bye-bye. So I'm now joined by Rachel Kenna, and Rachel is the Chief Nursing Officer with the Department of Health. Rachel, thanks so much for joining our webinar and giving us some of your time this afternoon. Rachel, as you know, this webinar, our second Sláintecare webinar, is looking in particular at new ways of working, in particular new ways of working that are perhaps promoting integrated care. So we wanted to come to you in your role as Chief Nursing Officer to ask you to speak to us this afternoon just a little bit about some of the new ways of working that you're seeing in nursing or across the system that you think are really worthwhile promoting and telling us about. So over to you, Rachel.
Okay, thanks, Gráinne. I'm delighted to be here and to get this opportunity to showcase maybe some of the different ways that we've had to engage with our patients and the services throughout the COVID-19 public health emergency. In lots of ways, it has been a time of opportunity as well as a time of significant change. And I suppose as Chief Nurse, I've been very close to the services and watching what has happened. And I have to say that, you know, the response has been phenomenal in terms of, you know, the change that has had to happen and what people have had to do to deliver care. So I took the liberty of getting some really good examples of some of the changes that we've had to do and adaptations that have to be made. And while some of these are still being evaluated fully, you'll certainly get the sense of how the difference that they've made and how people have changed. And I hope it gives some insight into what we've had to do. So, for example, one of the first places that I went to was midwifery. You know, babies still were born during the COVID-19 pandemic, thankfully, and most of them very, very well. But the pregnant mums needed a lot of support, and the supports that they normally got were through antenatal classes and coming in and out of their maternity hospitals or their maternity place of choice. So a group of the midwives down in Mullingar Hospital got together and they ran and coordinated antenatal classes virtually. which meant that they could both increase the number of classes that they had and also facilitate more of them on a weekly basis. So in this particular setting, they facilitated 2 classes a week, and they would have had up to 20 couples that would have attended the classes and got the support. And then they evolved it into, because the connection was made with the mums at home and obviously protecting them at a very vulnerable time in their pregnancy as well, they set up virtual support classes then to follow on with things like breastfeeding and kind of postnatal care as well for new moms. So I think probably when I was talking to them, they're not going to go back to just face-to-face contact for expectant mums and families, because the virtual worked so well, and it also gave people, you know, kind of more flexibility when they could attend and how they could attend, etc. But it meant that we could reach as many mums as possible through the midwives, which is obviously an important achievement. So I think their model now is a hybrid kind of approach to antenatal care, which will be a virtual and a face-to-face model. So I think during COVID, that was probably given the push it needed to happen.
So we're seeing kind of the best of both worlds there then. Mums or prospective mums can feel safe, and at the same time the professionals can reach them, get to them, provide the information. And I love the idea then that after support can also be provided in that way. So that's great story. Thank you.
Yeah, okay. One of the other areas I think that we were probably all caught with was the nursing homes and the impact that COVID-19 had on the whole older persons population and care in that area. So 2 fabulous examples and really similar approaches, but just showing the impact, was nursing home outreach teams led by advanced nurse practitioners in Tala Hospital and in Vincent's University Hospital in Dublin. Now, I'm very aware that these happened all over the country, but these were just the 2 teams that I spoke to. Historically, before COVID-19, these services did exist, but where they existed was in the hospital setting. So the advanced nurse practitioners of these teams would have gone and seen patients who would have been admitted from a nursing home and got involved in their care while they were in the acute hospital setting. But with COVID, obviously, there was a new requirement in terms of support for nursing homes. So both these teams, what they did was they couldn't facilitate the on-site or the patient-to-patient visits as frequently. So they set up an advice line so that nursing homes in their areas could contact the advanced nurse practitioner. So you've got a senior clinical decision maker then that was accessible. And what they did was they set these up 7 days a week, which was an extension to access to the advanced nurse practitioners. And they ran from 8 o'clock in the morning to 8 o'clock at night. So that was an extension of both hours and accessibility to senior clinical decision makers. This was done as a collaborative approach, obviously, with the gerontologists. So they had access to specialist consultant care as well during those hours. And it was open to all patients in the nursing homes. And any patient, I think the thing I liked about this one was any patient who presented to the emergency department from a nursing home in that area was automatically medically admitted under this outreach team. So they started to coordinate their care. Now that was a new kind of development, and that they would be followed up by the advanced nurse practitioner then when they went back to the nursing home environment. And from the onset of COVID, which was around March time, mid-March time, up until the end of May, they had seen over 100 patients that had presented to the emergency department. And 75% of those patients were actually transferred back home to their nursing home from the ED environment with the supportive and follow-up care from the advanced nurse practitioners. And they used a multimodal approach to follow up. If they felt they needed to go out onto the nursing home site, they did. But most of the time they used technology such as Zoom or these kind of modalities to be able to check in with the nursing staff in the nursing home. So we created a much more integrated approach across acutes and community, and it's certainly something that we're anxious not to let go of now, particularly in light of the growing needs within nursing homes and protecting that population. So,
and just on that, in terms of holding on to these good, as you say, people don't want to let them go. For that one in particular, what do you think will be needed to hold on to that new way of working? What kind of supports or push will we need to retain that really good model?
I think, I mean, key to it, well, obviously there's some resourcing in the fact that making sure that you have the teams in place. But I think we've already got the flexibility and people have changed their ways of working, their hours of working. But we are going to need increased, you know, flexibility from other team members. I think the team in Vincent's very much had physiotherapy involved in the work they were doing as well. So a kind of growing the multidisciplinary approach, I think, is probably going to be the one thing that we do need to think about when we're doing this kind of really integrated approach to care. So I think probably resources in terms of staffing, and then obviously having the technology platforms to allow that constant link and that flexibility in terms of approach. Because you know yourself, it's so hard to get somebody on the phone when you need them, but if you can see them face to face and they can see the patient, that makes a big difference to, you know, a trained person to be able to do some form of assessment. So technology and staffing, I think, are the two key kind of enablers for this to continue.
Very good, great stuff. And do you have one more you want to share with us?
I do have another example, and I've two actually, if you have time. One is a very short one, but just to kind of show in the context of Sláintecare, and I think this is really important. Donegal is an area that is very well served by public health nursing, but geographically it brings huge challenges in terms of reaching people.
Spread,
so we had to really up there with the team put their heads together and say, how are we actually going to manage this, because they wanted to keep as many people in their own homes as possible, but obviously a lot of the people that they were dealing with in the community were vulnerable. A lot of them were cocooning because they were of that age. So what they did was they pooled two nursing teams together, and they divided the whole team into geographical locations, which is interesting because that's one of the kind of thinkings behind how Sláintecare might actually mobilise. And that meant that there was a reduced number of people going into each home, which kind of, you know, supported the public health messaging about suppressing transmission of COVID-19. But also enabled relationships to be built up and to extend the care that was delivered in the person's home. Then they also implemented that service over 7 days and worked from 8 to 8 so that they could reach people. But it was just there was nothing different done in terms of the care that they delivered, but just the way that they did it and geographically reached out to patients was really important. And actually they kept all of their patients at home during COVID-19, which was a huge success. So that was really, so that was kind of a good news story, and certainly worth thinking about for the future. And then I suppose COVID-19 was very challenging for lots of ways, and we had to do things that we wouldn't have probably normally thought of in the context of, we lost a lot of people to this disease. And so one thing that was really important and became very relevant was enabling and supporting people to die with dignity in their own home and with their own families. And particularly given the challenges of visiting and access to hospitals during the time families weren't with them. And there was one team in Kerry, they called themselves the Twilight Team, and they worked very closely with the palliative care team in the hospital. But what they did was that they facilitated people who, you know, with the decisions through their families who weren't going to survive through COVID-19, and they went out to their homes with them and supported them through this very difficult time, but surrounded by their families in their own homes. And from March until June, they supported 84 people in this setting. But I mean, we do have a case study of one man who would have had to be in hospital 80 miles away. He had special needs, really complex medical history, and it would have meant that he would have died alone, and he has never spent a night away from his family, and he was 69 years of age. So I mean, the feedback from the family in terms of what the support did for them and just enabling that, you know, process, which is really important to nursing. That's very much part of our job, is, you know, to save lives, and if we can't do that, is to support a dignified death. And in a pandemic, when you're getting a tsunami at that end of the spectrum of life, it's really important that we're able to intervene and be able to be there for patients and families. So I think that one in particular caught me, is that it would never have been something that we would have planned to do. Obviously, nobody plans to have to be able to support an increase in death. It's not about what we are, but when we have to, it was a fantastically successful in its own way intervention. And being able to reach out to people in their homes again kind of fits in with the Sláintecare approach, that much more of this needs to be done where people are surrounded by familiarity and those that love them. Really
Absolutely.
important.
I mean, that last case study is it's poignant, but as you say, it is also pointing out to one of the key caring elements, which is, you know, at end of life, to be able to die with dignity. And of course, some of the stories we heard of people not having anyone that they knew or loved near to them, I think they really affected all of us who's lost anyone, to think that might happen. So that's a lovely story and a lovely practice that has been able to be developed. Rachel, thanks so much for bringing us those new ways of working. I think they give us hope. They're inspiring. And I suppose what I'd like to do through you is to thank all of the wonderful nurses and nursing practices that have happened over the last, and indeed that happen every day in our hospitals, in our wider community, and to thank you and them for all the work that you do. Thank you very much for joining us this afternoon.
Thank you, Gráinne.
So very interesting examples from Colm and from Rachel of ways of working, promoting integrated care right across the health and social care system. Indeed, as Rachel told us, from cradle to grave. The key elements coming out there: collaboration, flexibility, and allowing innovation that people want to do, allowing the innovation to happen. These seem to be enablers evident in what we've heard. And indeed, they are evident in the projects we're about to hear about in the next part of our webinar. So we've 162 people registered listening this afternoon. You're all very welcome. Some of you who joined later are wondering if the videos will be available that you missed at the earlier part of the webinar. Yes, they will. So you will be able to watch them separately. So showing new ways of working, supporting integrated care are 7 social prescribing initiatives. Many GPs and hospitals are now referring patients to social prescribing programs, linking them into activities and supports that help people who may have complex health conditions, plus social isolation, anxiety, and loneliness. For many listeners, social prescribing is a new phenomenon. Social prescribing projects all show the vital citizen empowerment and engagement element central to Sláintecare, whether that means keeping people well at home and in their community while supporting self-care and self-management where possible. They also show clearly the crucial partnerships being forged between healthcare professionals and community services. Let's hear some introductions from the 7 projects, and then we'll hear some detail about what social prescribing is and how each of the projects are delivering new ways of working, benefiting so many people in a variety of settings.
Hi, my name is David Robinson. I'm a consultant geriatrician at St James's Hospital, and I'm co-chair of the Social Prescribing Network of Ireland, representing the south of Ireland. We're going to hear today from some projects on the ground describing who they are, where they work, and how they've had to change in the age of COVID, their novel responses, and how things have changed with us over the last 6 months or so. And I hope you'll get a sense of the potential of social prescribing and the impact that social prescribing is having on people and their communities.
Hi, my name is Roisin Ryder. I coordinate the Dublin 8 Social Prescribing Service, which is based in the F2 Centre in Rialto, and we're a family resource centre as well.
Hi, I'm Concepta de Bruin, the HSE's Regional Social Inclusion Specialist, and I work very closely with the Dublin 8 Social Prescribing Project in the South Inner City.
I'm Susan Smith. I'm a GP in Inchicore in Dublin and in RCSI, and I'm coordinating a project involving link workers based in 10 general practices in disadvantaged areas in Ireland, and the link workers will help to support the coordination of health and social care for our patients.
Donna Laughlin here from Waterford Social Prescribing Service. We're based and led in the Sacred Heart Family Resource Centre, Waterford City.
My name is Alexandra Kelly. I am a Social Prescribing Wellbeing Coordinator for Aspire project, and we are based in Bray and Great Sons area.
Hello, my name is Niamh Herbert. I'm a community link worker based in Middleton Family Resource Centre, and my project covers East Cork. I'm also part of a health and wellbeing community referral pilot that began in Cork and Kerry in February.
Hello, I'm Peter Walker. I work with HSC and CHO1, leading out on a project for social prescribing covering Cavan, Monaghan, Leitrim and Sligo and linking with Donegal. Okay, I'd like to try and describe what social prescribing is. It's very much about planning. It's an individual-led, person-centred, holistic wellbeing plans are at the core of it, so that allows for citizen empowerment. It's facilitated by community navigators or link workers or coordinators, so it helps provide the right care at the right place and at the right time. It's very much about reconnecting. It reconnects people that are disconnected, and it helps them begin the process of reconnecting to community and to self, and it helps manage chronic disease in the community. It's about engaging. It's about connecting people to local activities and services which supports self-care, self-management, and supports their health and well-being. It's very much evidence-informed. It combines the medical and social determinant models of health, but what it is not is neither counselling nor a panacea, but it does aim to help keep people well at home.
As I said, my name is Niamh Herbert and I'm a community link worker based in East Cork. Today I'm going to tell you about the role of the link worker. You have to trust me when I tell you I can talk all day about this. But for the purpose of this presentation, I've broken it down into 3 main areas that I have experienced. So we work with people on a one-on-one basis. We promote person-centered support. We meet with the person and find out what they want and need to improve their health and well-being. We then link them into services and supports with the aim of improving social connectedness within the community. We also map our services in the area, and we build strong relationships with various community health services. This enables us to spot gaps in supports and services in our area. It's also important that we have strong links with our health professionals, for example, GPs and other primary care professionals. If we can support the healthcare professionals by offering people a more holistic model of care, we can promote self-management of physical and mental health issues at home or in the community. My health and wellbeing project was running 5 weeks when our centres closed down due to COVID. I had 2 or 3 referrals at that point, and we really had to use our initiative to adapt our role to the most basic needs in the community. What followed was the Sláintecare objectives: right care, right place, right time, right team. These objectives were rolled out in the most basic form, reaching the most vulnerable people within the community. Some examples of my work over the last few months include: we were providing people meals and wheels, delivering hot meals to people in the community. This also doubled up as a welfare check, because often we were the only person who was calling to them during lockdown. Supporting these services enabled us to organise further supports, such as taxis to and from hospital appointments, taxis to and from GP appointments. We were able to organise care and repair to go into people's home and make small, life-changing improvements during lockdown. For example, fixing phone lines, TVs, installing handrails. Even now, we've had to think on our feet, as there are no groups running in my area. As link workers, we are using our initiative and making our own groups for wellness, for example, walking groups.
I'd want to talk about the benefits of social prescribing. Really, how a social prescriber responds to a person depends on the needs of that person. Evaluation tools are used to measure these benefits. We work with Trinity College on evaluation at the moment. Certain groups of people who are socially isolated or with changed home circumstances, people with stress, anxiety or depression, cancer survivors, people with disabilities, or indeed what's coming through and has come through in COVID, especially is parents of children or adults with disabilities. They benefit hugely from social prescribing intervention. These groupings are often more isolated because of their circumstances. facilitating people who are lonely or isolated to join a group, make friends or have fun, or indeed getting peer support like parenting groups, women's support groups, etc. They benefit approximately 1/3 of people who use the Dublin 8 service. Stress, anxiety and depression obviously need a more considered response. Counselling, stress management courses, confidence building groups. This grouping often need additional emotional or motivational support even to access these supports. Also, what is sometimes needed is just a simple navigation to appropriate supports, housing, domestic violence services, disability, parenting, educational supports, and that is information that a link worker has access to. The benefits obviously also are connected with the GP services. In Donegal, there was a 20% drop in visits to GPs because of social prescribing, and the hospital anxiety depression scale, which we use, measures sort of a lower anxiety and lower depression after availing of social prescribing.
Social prescribing in Dublin 8 is all about collaboratively working to align service improvement agendas with clinicians from St James's Hospital, GP practices, community networks and the local community. Together, we have strengthened the development of social prescribing outcomes for service users in Dublin 8. I assisted the Dublin 8 social prescribing group in the community to do this by understanding what is good practice and sharing the learning among different networks. This collaborative working has enabled Dublin 8 social prescribing to expand. Aligning networks and addressing unmet needs can be seen in how TUSLA have embraced this work and are now funding the new under 18 social prescribing model in Dublin 8. This new model was informed and scoped out by the Ballyfermot Network and the South Inner City Children's Services Committee in Dublin City Council. Together, we would not have been able to do this without the partnership with the clinicians, the community groups, the local authorities and the staff on the ground. TUSLA has been able to listen to us and address this unmet need.
In Waterford, we've reached out to community volunteers through hosting webinars. We hosted 3 webinars over the last couple of months. So we actually reached out to the volunteers who were meeting directly with the most vulnerable to let them know about social prescribing, as we thought would become potential referrals. We've did radio interviews and also articles for the Farmers Journal and Fisherman's magazines. We've also engaged in teleconferencing with the primary care teams to ensure that they knew that we had continued to take referrals. So over the last couple of months, we've worked with 120 clients through calls, FaceTime, Zooms, etc. We've continued to support people and signpost people and support them to access online services, local volunteer groups, community-based drugs workers, etc. We've also supported clients to get up and running on social media. So we've set up a lot of online Zoom mental health grow and also fitness programs specifically for our own clients. I suppose as well, to meet the needs of those who don't have Wi-Fi or technology or perhaps didn't want to engage online, we also put together and sent out wellness packs. So each client has received 3 wellness packs over the last couple of months. They've included things like garden seeds, a deck of cards. We got somebody to do up mindfulness CDs. So they each included a mindfulness CD, mindfulness colouring, crosswords, you know, hand sanitizers, things like that. So a huge amount of phone calls, FaceTime. We have a jokes club going on as well, and coffee mornings over Zoom. So a lot of interaction online, but a lot of meeting the needs while staying safe at home as well. Supported very much, I suppose, by a group of HSE and community representatives who are on our steering group, who are very committed to supporting people to stay well at home.
To respond to the local need and to bridge the gap in well-being services during COVID-19, Aspire developed and delivered an online well-being program over 3 weekly 90-minute sessions, focusing on stress, coping, and self-care in challenging times, including COVID-19. This included educational aspects, experiential, so learning, relaxation practices, and discussion or interactive style. We hope this will become a permanent feature of Aspire, that we can continue in independent mode to deliver the program and reach maybe harder to reach populations who cannot attend appointments.
Our project differs a little bit on the others that have been presented. We are building on the evolving experience of social prescribing across Ireland. One of the challenges for GPs has been familiarity with the model of social prescribing. So our plan is to base link workers directly in 10 general practices in Dublin, Cork, Limerick and Waterford. And those link workers will integrate with the GP teams who will identify patients suitable for social prescribing and refer them to the link worker. The link workers will also map all of the community resources around each general practice, and the practices are all based in disadvantaged areas. Another thing that's a little bit different about our focus is that we are targeting people living with multiple chronic conditions. So our client group may well be a little bit different to other social prescribing networks. And one of our key aims is to try and support the evidence underpinning social prescribing and the use of link workers. And we've designed our project as a randomized controlled trial. So we will be able to determine the cost effectiveness of placing link workers in general practices and the impact of this model of care delivery and coordination on patients, particularly in relation to their well-being, quality of life, and measures such as anxiety and depression that have been mentioned previously.
So we've heard from all of those projects, so I'll just tell you a little bit about mine. As I said, I work in St. James's Hospital, and I've helped coordinate LAMP, the Local Asset Mapping Project, which is a social prescribing project for older people attending our clinics, which makes it unique in Ireland because it's hospital-based. But we have the same problems of physical inactivity, loneliness, social isolation, and mild mental health issues here. Some challenges that have emerged during COVID with us, obviously, with a lot of services have reduced or stopped, and we can see that there's a danger of the link worker becoming the service, which isn't the intention. The link worker is a bridge to join up different services. There's an emerging problem with the digital divide, a divide of digital poverty, where some people have the skills or the technology, the broadband to access all these services online, and other people don't. Part of our response to that has been to do domiciliary visits. So our social prescribing coordination visits people in the home as well as online and as well as in our clinics. And we're up to north of 30 referrals in just a month, so it's getting very busy. We have evaluation built in because I work in Trinity as well, so we've applied for ethics to test or observe all of everything that we're doing. But apart from the challenges, there's a few things to look forward to. There's going to be the launch of the evaluation framework. This is specific to Ireland, commissioned by the HSE, involving a survey of all the social prescribing projects north and south of the island. And we're going to have an All-Ireland conference. Our annual conference will be digital online in November of this year, and hopefully to follow on from the success of the Waterford conference last year. So a lot to look forward to and a lot to do.
So great, thanks to all of those. Roisin, could I come to you first of all, just following on from all we've heard. In the Fatima social prescribing project that you're involved in, I think you've demonstrated the new ways of working, connecting staff and service users and patients across statutory, voluntary and community sectors. And I think you're managing a large amount of what I would call moving parts. But would you tell me maybe about one of the people you've been dealing with? Let's say you mentioned lone parents as a group that you work with. How do they come to your attention, and what services might they engage with as part of the social prescribing experience?
Yeah, I suppose initially, probably most of our referrals come from GPs, even though there's other agencies referring in now. And I'll just take one person, about a year ago, and she came in a lone parent with anxiety issues. And I suppose our first port of call was to link her to a service that would address that, a counselling service and that. But through the conversations came up issues around her parenting, lack of confidence, and also sometimes just getting out for herself, her own needs. So if you like, there was a range of link-ups with other places in Dublin 8 and within the community centre, working in a family resource centre, to service her needs. So it's like a wraparound response, and with quite an ease within the community sector. There's an ease of linking people into groups or whatever that person's needs are. So I don't know if that answers your question, but
yeah, no, that's great.
Yeah,
thanks very much. It's really interesting just to hear maybe the journey or the pathway that one particular lone parent that you dealt with had. So Concepta, I'm going to come to you first, if I might. In Dublin 8, what sort of results are you seeing from the social prescribing in your area?
In my area, I think, can you hear? In Dublin 8, we are doing an evaluation with Trinity College, which will be ready at the end of the year. So we'll have more detailed information on the statistical analysis of the results. But the immediate result that I can see is that we are building community resilience within the Dublin 8 community to tackle social isolation through interaction with social services, through the development of clubs and outlets. This type of therapeutic intervention is assisting the 37% of the referrals we have from the mental health services. We're keeping people out of hospital and we're keeping them well in the community. We're also seeing citizen empowerment because we're seeing the local community work together to respond to unmet needs, such as the unmet need in the cancer services, where they're dealing with chronic fatigue is one of the issues that they're dealing with for the cancer clients, and also the unmet need for social prescribing for the under 18s in partnership with TUSLA and the Children's Services Committee. So they're the immediate results, which are basically building that resilience base.
Yeah, great. And we look forward to seeing the full results towards the end of the year. I'm going to move on to our second new way of working focus this afternoon, and it's on urgent ambulatory care and the virtual ward. A growing older population in Cork presents difficulties for both providers and users of services. Currently, the only option for these patients and their GPs is to access urgent health care, is to refer to the emergency department to seek admission to hospital. The Cork and Kerry community healthcare people have devised a new pathway where such patients will have their needs managed in a community setting, and where possible they'll be treated and remain at home with the supports of a multidisciplinary team. So let's hear now from Spencer Turvey about what they're doing and the benefits of their approach for GPs, hospitals and patients alike.
Good afternoon. My name is Spencer Turvey and my role is Clinical Project Facilitator in Cork Kerry Community Healthcare. I'd like to thank Sláintecare for the opportunity today to talk to you about our project, which is ambulatory care for older people in virtual ward, aimed primarily at admission avoidance and hospital avoidance for people aged over 75. I'd also like to thank Sláintecare for the seed funding they provided us to enable us to commence the project work. The project is a collaboration between Cork Kerry Community Healthcare and the South South West Hospital Group, working in conjunction with our partners in the integrated care programme for older people, and also within the 5 fundamentals of unscheduled care improvement framework, which we work at in conjunction with the performance management and improvement unit in the HSE. And that's where we applied to the Sláintecare funding last year, and we were awarded a grant to roll out a small element of the project, which was to develop a rapid ambulatory care pathway to reduce admissions to the acute hospital from the ED. What that meant was that when patients presented to ED, they were assessed by a frailty at the front door team, and where it was able, they were discharged to the community, to the ambulatory care hub and to the outreach team to have their care needs delivered in their own home. This was done by a virtual case management approach. You see from the diagram there, really the core element of the project was the frailty at the front door response linking to the ambulatory care hub. The outputs from the project were going to be 10 less admissions per week, which would deliver back to the acute system 14 extra beds. Furthermore, there was collateral developments that rolling out this pathway supported. We were able to develop a single point of contact for older person services in the community setting. That improved the access to the services and ensured we got the right person to the right place in the right time. Within this pathway, 100% of the patients received a comprehensive geriatric assessment by a specialist MDT, either in the ED or in the ambulatory care hub or in their own homes. Again, it's giving the patients a thorough assessment to ensure that they're receiving the right care. And this specialist frailty assessment was key to be able to develop treatment plans for these patients that really met their care needs. We also were able to develop onward referral pathways, particularly to rehabilitation, to transitional care beds, and also to other subspecialty clinics such as falls or memory or dementia, and again, enabling us to deliver the right care in the right place. And overarching ethos of the project was really to deliver the care needs at home. We all know that older people do better functioning when they remain at home, so we were very keen that we delivered the care they needed within their own homes, again, emphasising the right place ethos of Sláintecare. Throughout the project, we have delivered our key milestones. Very briefly, we've opened a rapid assessment clinic in the ambulatory care hub. We've developed a very robust ambulatory care pathway from the EDs to the ambulatory care hub. So it enables older people to be assessed in the ED, discharged the same day, and have their care needs managed in the community. The Sláintecare funding has enabled us to provide a more thorough FIC team response at the front door. We have a CNS and a registrar now in our FIC teams alongside our therapists. We've also enabled the outreach team to be aligned to this pathway. Again, we've added resource to that team in terms of a physiotherapist and an occupational therapist, which again has increased their capacity. We've developed a system for transferring clinical information from the acute hospital to the community and back again. And we have ensured the onward referral pathways were robust and were able to manage with the patients that we were referring into them. And then this was delivered probably early 2020, and then along came COVID-19, where really we had to be very adaptable to the changing situation. What we noticed very early on was that there was a drop-off in ED attendances of greater than 50% in one of our hospitals in Cork, which really meant that the older people that we wanted to see, we wanted to assess, were actually avoiding hospitals due to the fear, I think, of attending and contracting the virus. So really that needed us to really change our pathways with this changing demographics. So we really decided to focus around hospital avoidance rather than admission avoidance. So we decided that really a primary care pathway would be optimal, so a GP could be referred directly to the ambulatory care hub rather than going to ED for these comprehensive geriatric assessments. What that enabled us to do was to actually develop a new scope of service for the ambulatory care centre and to actually realign that centre. We understood there was obviously significant capacity restrictions with COVID-19 and physical distancing, which meant that hub could no longer take the volume of patients that it was taking. So what we did there, we had to ensure that we gave the appointments in the hub to the most at-need older people, again using our single point of contact, and that we ensured rapid access through that centre. A significant portion of work we used to deliver from the ambulatory care centre has now been shifted to other clinics, so it has been delivered further into the community, and the hub is really focused on rapid assessment of older people. It also enabled us to develop further subspecialty clinics, particularly the falls pathway and the dementia pathway, so patients then could access directly into those services rather than coming to a hub or coming to another centre for assessment. It also enabled us to develop the outreach team scope of service further. So the outreach team used to deliver acute care for patients in their own home. With COVID-19, we didn't want these patients having to present anywhere for rehabilitation, so that team started to provide rehabilitation for up to 6 weeks on top of managing acute care needs. They also increased their capacity, which enabled them to deliver that service. And overall, in terms of the adaptability, the staff response to all of these was significant. Just to have a little bit of a look at the data, we can see there that the demographics of attendances to ED certainly did change. Our front door teams in April only saw 51 clients. In May, they saw 270. But most of all we notice here is that in May 2020, we were delivering 46 avoided admissions of older people to acute hospitals. That delivered 16 beds per week, and we were managing 42 admissions to the virtual ward. On top of that, we were managing 80 rapid assessment appointments per month through the rapid assessment centre. If we look at the enablers that enable us to undertake the rapid change during COVID-19, I think a key element was the leadership of the project. We had a very strong clinical leadership, but also a very strong corporate governance of the project. So that really made the clinicians feel they were empowered. They're empowered to make decisions on the front line in a timely way. And certainly the project leadership were very encouraging of the devolved decision making to move the project forward. And also the staff acceptance of that decision making authority was very positive. And also the staff acceptance of the speed of changes that we were making. Overall, I think the local ownership by the clinicians of the project enabled it to change and adapt during the COVID-19. I think outside of that, that was really the relationships there were built on a very core values, trust, and also that everyone was working to this right care, right place ethos. And we all knew what we had to do to try and improve the care pathway for our older people. In terms of the future direction, really we have to understand, is this sustainable? Is it sustainable to have a GP pathway directly into our ambulatory care running alongside an ED pathway? We have to have a debate around where we want to focus the project, but the key ethos is really we have to think about rapid access. So whatever path we take, and if we take both, it's okay, but we have to make sure it's rapid access. We really want to see the pathway taking patients with greater acuity. So we really want to do focus on the hospital avoidance to keep people away from acute sites. We think the pathway is scalable. We really have delivered a programme of reconfiguration of existing resources, plus the resources given to us by Sláintecare has enabled us to deliver a pathway that we think is scalable across Cork and Kerry. And we'd like to see particularly development of a Kerry hub into the future. I think the biggest element for us now is that we sustain these changes going forward. There's been very positive outcomes through the coronavirus crisis in terms of how we developed the project, and particularly how we've moved into this primary care pathway. I'd just like to see that this model is sustained, and I'm happy to take any questions. And thank you for listening.
Great, thank you very much, Spencer. I mean, it's clear, Spencer, from what you presented to us that, you know, your project really does exemplify many of the Sláintecare principles of right care, right place, right time, by the right team. Can you talk a little bit about future direction and sustainability, and how would you suggest that this model of integrated care, how can it be sustained and maximised to keep older people well at home and avoid unnecessary attendance at or admission to hospital?
Yes, okay. I think there's many elements of that question, really. I think sustainability is really about building capacity. I think if we're talking around a primary care and an ED pathway, we really have to deliver that in a rapid way, which is going to mean we need to put senior decision makers at the front door. The front door we're talking around is the ambulatory care hub. And that can be either our medical colleagues, or what we're looking towards in Cork is really developing AMP posts to be able to deliver that urgent rapid assessment, and also develop advanced therapy practitioner posts that can also deliver a similar type of input to ensure we build that capacity to be able to service all of our older population. I think that the scalability across Cork and Kerry is going to be a bigger challenge. Again, that's around building more than just one hub. I mean, if we look towards the future, I mean, we probably look to a programme of 4 or 5 hubs across Cork and Kerry to manage a population of around kind of 7,000 to 8,000 older people per hub. And that will really be a sustainable model going forward, but it's going to require investment and also new ways of working for all of our staff.
Absolutely. Great stuff. Thank you very much, Spencer. I'm going to turn now to our third presentation that we have today, showing new ways of working. And this is from the Cork Kerry Community Health, and it's a rapid response to COVID-19 for patients from vulnerable or at-risk groups, including those who are homeless, have addiction problems, or may be in direct provision, and includes travellers who may be in need of particular supports to help them access health care. Rebecca Lochray will tell us more about their social inclusion COVID response approach.
Hi, my name is Rebecca Lochray and I'm the Specialist in Social Inclusion in Cork and Kerry. Today I want to talk to you about the COVID-19 response that we put in place in our area. As many of you will know, in social inclusion, we're concerned with providing health services support to the most vulnerable and marginalised in our society. And we also support the health services to meet the needs of those people. In Cork and Kerry, there are a team of approximately 100 people involved in social inclusion, and they work across both urban and rural settings. Our services are divided into drug and alcohol services, homeless services, traveller health, community development and intercultural services, which includes refugees, asylum seekers and the Roma community. One of the features of social inclusion in our area is that we have spent many years building up a solid foundation of strong working relationships across both the statutory and voluntary sector in our area. We work very closely with the local authorities, with the Gardaí, with social protection, and also with a variety of community and voluntary groups. An example of this is my own role. I'm currently seconded on a part-time basis to Cork City Council, where I manage social inclusion services there, in addition to managing social inclusion services in Cork area community healthcare. And this is part of a joint approach between both agencies to look at collaborative approaches to health and well-being in Cork City.
When COVID started, we realised our clients were going to be particularly vulnerable. We knew we were going to face unprecedented demands for service. And in this regard, we knew we would have to completely redesign what we were doing to meet this need. Our aim was to protect our clients as much as possible. We did a number of things that we had never done before. We realigned the entire social inclusion team and all of our work. We redeployed staff in from other agencies to support us. This would have included staff from Cork City Council and from Cork Education and Training Board. For the first time ever, we put in place a social inclusion on-call rota, providing 24-hour cover from the 4th of March to the 22nd of June. We developed a social inclusion self-isolation accommodation initiative between ourselves and the local authorities, which ensured that there was accommodation available across Cork and Kerry for any of our clients who needed to self-isolate. A support worker initiative was put in place to ensure that every client who needed it had intensive support during COVID. We developed a transport initiative, again in partnership with the local authorities and with a number of NGOs, and this supported clients to attend testing, to move to self-isolation and to attend appointments. In partnership with Public Health, we undertook mass testing in a variety of residential settings, including direct provision. We undertook some joint work with the ED departments in Cork University Hospital and the Mercy University Hospital. We participated in the Community Response Initiative led by the local authorities, which supported people cocooning in local communities. And we were able to do all of this because we had a very strong, committed, client-focused team. Thanks to the strong support we received from the management team in Cork Area Community Healthcare, we had the ability to bring in staff quickly and allocate resources quickly. This enabled us to move rapidly and put in place immediate responses to issues as they arose. Because of the urgency required, we were open to trying everything and anything to support the clients, and this yielded innovative and creative developments, the like of which we had never envisaged. But the key element in all of this was the team. The social inclusion team were just amazing and had a huge openness to new ways of working and a can-do attitude. The overall initiative has had a number of short-term and longer-term outcomes. Since March the 8th, the social inclusion team have supported over 400 clients. We've provided over 1,000 bed days of accommodation and over 450 trips with our transport services. During this time, we dealt with 5 significant COVID-19 outbreaks, including a very large outbreak in one of our direct provision centres.
This case study relates to a couple, John and Laura, who are long-term homeless and sleeping rough in Cork City. During COVID, they presented to a doctor in Arbour House Drug and Alcohol Service, where upon examination, COVID was suspected. Both were referred immediately to the social inclusion self-isolation accommodation. This couple has very complex needs, including active addiction, ongoing engagement with the criminal justice system and with TUSLA, and both were in our methadone program. An appropriate apartment was identified from our self-isolation stock, in this case an apartment provided by Cork City Council. The support and transport teams put a plan in place to support the couple to move to the apartment. However, due to their vulnerability, their continued substance use, and their fear of self-isolation, there were challenges to arranging a move. It took 3 attempts to support them into self-isolation. The move finally happened when the GP from Arbour House went and visited them in their tent and provided reassurance by talking them through what was involved with self-isolation and stayed with them until the transport arrived. On arrival at the apartment, their support continued. when the support worker met them at the door and again provided reassurance and practical support. During their time in self-isolation, the support worker visited daily, delivering food and medication, including their daily methadone. They also received daily phone calls and check-ins from the social inclusion GP. Following their initial period of self-isolation, where both were tested and no COVID-19 detected, rather than exiting them to rough sleeping, we made arrangements with Cork City Council and Cork Simon to identify further accommodation. We supported their extended stay in self-isolation while a move to appropriate supports was being arranged. The current situation is that John is now engaged in a residential treatment programme and Laura is accessing housing and support through Housing First. While they are only at the start of their journey and there may be challenges ahead, our view is that the intensive support they have received during COVID has played a significant part in supporting them to take this next step. So that concludes our whistle-stop tour of the social inclusion response to COVID-19 in Cork and Kerry. We're extremely proud of the work that we've done, and we're already seeing the benefits for both our clients and for the ways that we work. We strongly believe that we're meeting the ethos of Sláintecare in terms of providing the right service for the right people at the right time by the right team. If you would like to hear any more about what we've done, please contact us. Thank you.
Thank you, Cork.
Great, thanks everybody. Rebecca, just before we move into the panel discussion, can I ask you, what is required in your view to maximise and sustain this collaborative partnership that you've built, which is obviously able to meet the needs of some very marginalised people like John and Laura in your video?
Thanks, Gráinne, and hi everyone, and thanks for the opportunity to present today. We're delighted to be here. I suppose just a couple of things, Gráinne, in terms of maintaining the collaborative partnership approach. One, I suppose, is the importance to build on collaborations that would have either existed before COVID or ones that would have developed during COVID. And important not to lose the good work that was done. I suppose everyone across the service has been required to work in a different way. Strong relationships have been built, and some really good models of good practice have been developed. And it's really important that we work to retain those. But in order to retain those, I think it's really important that we have the organisational support and the buy-in from all the partners. And I suppose in talking about organisational support, I might just say just a tiny bit about resources. In that a lot of the work that was done during COVID didn't require significant additional resources. It was more about repointing existing resources, but that is only sustainable if our existing base is solid, if our vacancies are filled, and if our services are resourced adequately. So I would say that I suppose a good foundation on which to build collaborative work would also be a key priority going forward as well.
Great, that's really clear. Thanks, Rebecca, for that. Just to say to people that the video of the whole of the webinar will be online from next week, and we will send a link by email to you. So if you missed the beginning of it, you will be able to watch it next week when you get the link.